All right, everyone, I have to say, we thought we were going to present to 0 people, so thank you so much for being here. We wouldn't mind. We just do a little dance up here and talk to each other. We could do it, but we also thank so much our audience online. We have about 70 people watching, so it's super exciting. I'm going to talk to you a bit about headache updates, really focused on migraine. Dr. Robbins is going to talk to you about other headaches. I tried not to take his shine, though actually there's only a little bit to talk about other headaches. Unfortunately, migraine, I think, gets the most attention in our field. I say unfortunately because there are so many headache disorders out there, and our patients come to clinic who don't have migraine, and I have to say it's the hardest visits because they are very frustrated that the field is really not focusing on anything other than migraine, and it's hard for them to understand. So it's always exciting when we do see research that's being dedicated to other parts of headache disorders. It's important for us to bring that back to our patients. So for those of you who haven't visited our Capitol in the past, this is our Capitol building. I hope you look at it now because we'll see if the future holds. It is a beautiful place. Come visit us sometime in DC. These are my disclosures. I will say they're very relevant because all of my work is actually focused in migraine, so my disclosures are all the work that I do, the research and the consulting work. The only thing that's not relevant is I actually do some editorial work for Self, and right now it's all on Alzheimer's, so I've actually been learning quite a lot about dementia, so that's been pretty cool. We're going to talk about a lot of things in a short time, but I promise I don't actually have a lot of slides because my 2 very close friends up here will tell you I am a chatty human. I do not need a lot of slides to talk about what I find interesting, but I'm going to really focus on where the field is trying to move and how us as clinicians and researchers are trying to push the field in a very specific direction. And if you've been looking at posters at this meeting, and if you've been listening at the talks that are focused on where the future's going, none of this should look very new. But it's an important conversation, I think, if you are a practicing clinician and get frustrated when you go to work every day, no matter what disease state you're looking at, and feel like the research doesn't resonate with what I'm seeing in front of me. I think this is a really good talk that focuses on what you can do to make sure the future of research resonates with your patients, because I think a lot of what I'm going to talk about is how we have taken the clinical space and are trying to move research into what we're seeing as clinicians. So I want to start with a discussion on the phases of migraine. Some of you might have learned about the fact that migraine is not just headache. Though we say this a lot. I have been in practice for 16 years as a headache specialist. All I talk about is headache. I mean, of course, know that they have to have nausea or light sensitivity. I practice in a dark room, which I'm very comfortable in. We keep it super quiet. We have actually really located ourselves to, like, it's a hall that's just a headache clinic, and we separated from our movement clinic because they were just too loud because the patients couldn't hear anything, so everybody was shouting all the time, and that was very disruptive for our patients. Inherently, I understand that migraine is more than headache, but somehow that's all we ask. How many headache days have you had? How many headache days have improved with the treatment I put you on? Because that's the language the patient understands. If I ask them about migraine, they don't really answer the question. They talk about headache. Or if I talk about migraine, they only talk about the worst attacks they have. So we've sort of morphed in clinical practice to really focus on that third phase of migraine, the headache. And our treatments have really focused on, in the acute space, treating headache pain, and maybe nausea, vomiting, associated symptoms get better too, and some of the research has focused on that. The trouble is, the phases of migraine are quite numerous, and I like this way of thinking about it as a circular system because you'll always see it plotted as a straight line, right? It's a kind of a straight line as a bump where it's very it comes in a very ordered system. I mean, that's not really real life. It's very circular. A person might start in a certain place and it just kind of keeps going, especially if they have a couple attacks a month. It's not really so straight. And in these phases, 60 to 80% of patients get some symptoms way before the attack starts, way before the pain starts, sorry. And these symptoms can be warning signs that the pain is going to come up to 2 days later. 2 days. So it's really hard for that patient to recognize that light sensitivity might be the first symptom of their migraine attack and not, in fact, a trigger. So it's important that we recognize that if we don't ask our patients and talk about all these phases, we are missing the onset of migraine, which does come with a large disability. So of course, I'm going to talk to you about prodrome, which is technically the first phase of migraine and probably affects up to 60 to 80% of our patient population in migraine. I do believe as a clinician, this is really hard to identify in clinic. They are, of course, questionnaires that are very long, and I will tell you, I do not like to use these kinds of questionnaires in my practice because you can give a patient a questionnaire and let them fill it out themselves, and then you can ask the questions yourselves of the patient, go through it with them, and get two completely different sets of answers. I don't have the time to walk my patients through a questionnaire, so if I can't do that, I'm not going to just have them answer questionnaires on their own. I don't think that data is always going to come back very reliable. So I really liked the study that was done for multiple reasons. This was a study looking at the use of ubrogepant at the onset of prodrome in a very subselect group of patients, and I'll get to that in a second. And why is a subselect? And they used ubrogepant and they used placebo, and they treated prodrome that started about 6 hours before the actual pain of migraine and showed that this was an effective treatment. Prodrome went away, and for many of the patients, the actual headache pain didn't start with associated symptoms. Now, why was this an important study? This wasn't the first time in the field of migraine we attempted to treat prodrome. But it is very difficult to treat something that could start up to 2 days before the pain attack when you don't have a treatment that can last for 48 hours. And so we had tried looking at triptans. There's a study looking at naratriptan, one of our longer triptans, and pre-treating or treating at the onset of prodrome and seeing if that stops prodrome and stops migraine, and it wasn't an effective study. That's a great example of how if you don't design a study to shorten the time length of what you're looking at to match the drug, the study isn't going to necessarily show efficacy, meaning if the drug's only in your system 4 to 6 hours, the patient has to have the symptoms for only that duration. Difficult thing, you have to then pick out those patients who are only having symptoms for that duration. Another trouble that might happen with why a triptan might not work during prodrome is there is some theory out there that the target for the triptan, the receptor where it hits at, isn't necessarily exposed until you actually have pain of migraine. This is some scientific work that's been done in the past on mice models where they actually can't see the triptan receptor exposure until pain starts. Very intriguing. It's not a lot of work done in that area, but it also brings to question why. Why is that receptor not exposed until the pain start, not there at any other time? There's been some studies looking at, what might cause prodrome. We think dopamine might be involved. What if we give anti-dopamine agents during prodrome? Can that be effective? Well, those studies didn't really show any efficacy. And so when the study was being designed, I had that opportunity to have the seat at the table and said, I don't think this is a good idea. We haven't been able to prove that this would be an effective way to go about treating migraines, so I don't think you should invest your money in this study. I'm very glad that there were smarter people at the table there who said, no, I think that's a terrible suggestion, Jess. This is really important. Patients are really disabled. We need to find a way to design a better study. So the thought was, what if we find patients who had shorter prodrome? We find patients that only have prodrome a few hours before the actual head pain, and we subselect that group, and then they treat with the treatment before the actual onset of head pain. So for this study, they had to find a group of patients that had prodrome that was, it always occurred, and it would be 6 hours before the attack, and then they would take the treatment at that time. So this wasn't every patient with prodrome, and I think that's really important to understand when we take this evidence to clinical practice. It was patients who had predictable prodrome that was 6 hours before the head pain. So what did I learn from this study? I thought hey, that's great, fine, let's see if this works. It worked, that was interesting. Another thing I found was interesting was they were able to pick out what were the most common prodrome symptoms. So in clinical practice, this took a 36 questionnaire and brought it down to a couple of questions I can ask my patients. Light sensitivity, fatigue, neck pain, sensitivity to sound, and dizziness. So now, instead of handing them a questionnaire, I can just say, do you ever notice that that you want to shut the lights off a few hours before you have pain? Do you get nauseous, or do you get tired or dizzy right before the pain starts, just a few hours before? That has brought my ability to identify or help identify prodrome to patients up to about 90%, whereas it was really difficult to do that before. Other things that were found in the study that I didn't put here, but they're in the articles, is the disability rates of prodrome. If we just look at prodrome, the rate of disability, the burden of prodrome is really high. So by not treating, by not talking about it, by ignoring this entire part of the spectrum, we're really harming the patient. And so it's important to have that discussion, important to identify and see if we can actually start treatment earlier, especially now that we have identified a treatment. Well, in the phases of migraine, we have prodrome, we have aura, which occurs in 30% of patients. We have the acute part, the resolution, which is postdrome, which we don't have any studies in, and I think this is an area we really can move into. And then there's this sixth phase, which you often won't see on the straight line graph, but the in-between or the interictal time period. And we know that for the patient who has 4 to 5 migraine days a month, as Dr. Hawkerson was just mentioning, we have studies that show the burden rate is really high for that patient. The interictal burden is actually really high. That's when they're really fearful about that next migraine attack, their anxiety goes up, they have a hard time making plans because 5 days a month is more than 1 day a week. Right? It's really hard to say when that attack is going to happen, and can you make plans? Are you reliable as a family member, as a friend, as someone who can get to work? And so there becomes this anxiety about the next migraine attack, but not everyone wants to be on prevention. So you sometimes run into difficult situations. What if there were ways we could start to do something about that interictal time period and start to make a move into being able to treat situations, what we call situational prevention. So really moving even before prodrome, where a patient can identify certain situations they're going to be in that every time they're in that situation, they end up in a migraine attack. So things that I hear in clinic very frequently. Being in DC, we are in an area that patients are constantly flying and are traveling a lot for work, sometimes international. So it's very, frequent that I hear every time I fly, especially when I'm going coastal or I'm going international in these very long haul flights, I get a migraine attack. And then this is really problematic because often when I'm making these flights is for work and I have to be on point when I land and go right into meetings, and I'm out for 3 days because it's a terrible attack and I can't get on top of it after the flight. Or I had a story where I have a patient of mine, she's in her 70s, she's retired, lovely lady. She's on prevention, we've gotten her attacks under beautiful control. She has 3 to 4 attacks a month. She was telling me once when we were in a visit that she hasn't traveled outside of just going somewhere in a car in decades. And she would love to see Europe in her 70s. And I was like, what are you talking about? She's like, every time I fly, I get this awful status migraine attack and there's absolutely nothing that works for it. And I can't do it. I mean, wouldn't it be great if we could put them on something and stop that situation? I want to have a glass of champagne at my daughter's wedding. We hear this a lot. I want to have a glass of champagne at my wedding. Is there something you could do to help me through that situation? So we wrote this article about these types of situations and, are starting to design studies where can we look at situational prevention? Is there a treatment that we can give a patient where it's a safe treatment, has relatively few side effects, and we can give it to them in a situation that they're going to be in to prevent the migraine attack from happening? And so specifically right now, some of my work is focused on looking at a treatment like rimegepant that has a longer half-life to give the patient this treatment during situational time periods. And there was a poster presented by one of my colleagues looking at Ramadan during a fasting period, another very frequent time, of situation that causes migraine attacks. And his poster showed the reduction of migraine attacks when a patient was placed on rimegepant during the month of Ramadan. So again, moving to this idea, not of placing a patient on prevention long term, but can we get better control of the migraine during that time period? All right, so moving on to another idea. We presented some of this data last year at this meeting, but the idea, if we're using these new treatments in clinical practice, What happens when we start combining some of these new treatments together and blocking CGRP in multiple ways? Is this really a safe thing for us to be doing? We have real-world evidence that looks at combining CGRP monoclonal antibodies with GPANs, which block oral treatments that block the CGRP receptor, where patients are using a monoclonal antibody for prevention and are using the GPAN for acute treatment. And the real-world evidence suggests that it is effective and can be relatively safe, but it's real world, it's not very long term, we don't have like a lot of evidence. So we started to think about the idea of what happens when you use a GPANT for prevention and then take a GPANT for acute treatment. What does the safety look like? And the responsibility of doing a study, because regardless of what you tell people, people are going to use things together. And so it is important that you design studies to actually see what safety looks like. So this was a study looking at patients who had episodic migraine, and it was a phase 4 open label type of study. So patients were started on atogepant for migraine prevention at its highest dose of 60 milligrams, and then after a month were given ubrogepant 100 milligrams to take as needed for migraine attacks. The goal here was looking at safety of combining these treatments. What happens? Is everything okay? The liver function okay? My actual concern was, do they end up not pooping for like months? Because that would be my bigger concern. And were there any cardiac issues? The blood pressure was okay, heart function was okay. What does everything look like? And so just bottom line, safety endpoints all look like what was on drug label. Patients, when they started atogepant, had a little bit of constipation, got better over time. There was no new constipation when ubrogepant was added, so that was actually a big surprise for me, and I was pretty happy about that. Surprisingly, we didn't think about the fact that we were starting preventive treatment for patients, and so actually after the first month, frequency was starting to drop, so patients weren't using as much ubrogepant as we thought they would use. Majority of the patients were using 2 to 3 tablets a month, but we did have subgroups where some used it a little bit more frequently, and a small portion of patients were using it up to 10 days a month, but the average was around 6. So I think this was important for me because at least I felt a lot more comfortable when a patient was on prevention with atogepant to allow them to use ubrogepant as needed. But I do tell my patients I'd like you to keep it under 10 doses a month because we really don't have a lot of data for safety above 10 doses a month. And if you look at the primary literature for ubrogepant, the maximum used in those studies were 8 days a month. So it's kind of within that safety range. I wanted to move on and talk a little bit about an area that we're probably going to learn a lot more and see a lot more in the world of migraine, looking at cognition. We know our patients, when they have migraine, talk a lot about cognitive fog, and they call it brain fog. And I can tell you, I don't know what that really means. The field isn't really sure how to identify brain fog into clear terminology. And so we know it exists. There's a MICOA study that is actually funded by the FDA that's trying to break this down a little bit more and have a better understanding of what are these memory issues that are occurring in migraine and when are they happening. So right now the study has shown that patients with migraine are having actually cross-memory issues. There's language deficits, speech deficits, attention issues, executive functioning issues, and just global memory problems. And it's happening all across the board during the phases of migraine. Before it starts, during the headache, after the headache, and interictally, about 30% of patients continue to complain of cognitive changes. So why is this important? Well, when we look at brain fog as the complaint that patients have, there's 2 parts to that. The fear that this will be permanent, and is it migraine that's causing damage to the brain that's going to lead to long-term dementia? This is a question that constantly comes up. And the second part is, if it's related to the disease of migraine itself and we improve migraine, will the cognitive changes get better? So it is important when we're looking at studies if we can have another survey or patient-reported outcome measure, which there's so many of these, but they are important in studies, where we can actually start to look at these measures and take a look at how patients are doing before and after treatment. So there is a study with eptinezumab. It's a real-world study looking at patients who have been on prior treatments and they weren't effective, and they started eptinezumab. And they actually asked patients about bothersome symptoms, and one of the ones that came up was cognitive dysfunction. And they asked before and then after starting eptinezumab how patients did. And the reason I pulled up this piece of data is because this is one of the few studies we actually have a little bit data on this brain fog, concentration, memory issues that almost 78% of patients reported this as a bothersome issue. And post-treatment, many of them showed improvement after treatment. So you can see that for 5%, the issue's completely resolved, but that's a small number. But 32% felt very improved, 26% moderately improved, and 23% slightly improved. So there was improvement with treatment. Again, how is this important in clinical practice? I hear about this a lot. I'm not sure how to ask the patients about it. But if this is a big problem for a patient, this is really concerning to them and affecting their quality of life, and I have data for a particular treatment that, hey, this might be something that can improve, and a patient is choosing treatments. We have options. We're trying to decide which one are you going to go with. I can bring this piece of data back and say, hey, we do have this data point with this particular drug that patients like you showed an improvement. So what do you think? We can give this a try and see how you do, and then we can focus a little bit on that, how they're doing after. So now I want to move into, just for a few minutes, talking a little bit about consensus guidelines and where we're really placing our treatments, because I can say you have choices for patients, but I know a lot of us in practice feel like, no, Dr. Alani, I don't have a choice. It's whatever the insurance tells me that I can do, and I know that's a real struggle for many of us. So, the American Headache Society has been, since 2018, working really hard on trying to navigate situations on, we are going to have, and then now for many years have had these brand new treatments. How do we really organize when to use these treatments in clinical practice, and what does the data show, and how should we position these treatments? This is our third iteration on a consensus, meaning we didn't start out saying that our treatments that are migraine-specific should be one of the first-line treatments. We actually started by saying, we're not really sure because they're not out yet, and we got to see what they look like when they come out and what the costs will be, and if they're going to really be as safe as they look like in the phase 2 trials, because that's how far back we wrote the first consensus statement. The second consensus statement said, maybe you should try generics first. There's no head-to-head data yet, so we really need to wait and see. This was our third iteration where we actually said, at this point, we have so much data to suggest safety, efficacy, that patients stay on this treatment, prefer this treatment, that there is now a head-to-head study with oral generic versus arenumab that showed clear, superiority of arenumab because patients stayed on arenumab and they stopped the topiramate. So the arenumab was more effective. And that's why we said this could be one of the first-line treatments as well as some of our oral generic medications. The problems come in when there are multiple statements and guidelines, and this can cause a lot of confusion. And I think it's problematic because we know that 65% of patients start and stop their care for migraine in primary care. If your journey is going to start with your primary care provider, it is wonderful that they do have guidelines so that they have a sense of what to do. The trouble is if they have guidelines that recommends second-line, second-tier generics as a first-line care, it becomes a little bit problematic. And if their guidelines don't even match our AAN, like 2012 guidelines, there starts to become a problem on, why? What's going on, and why don't we match what we're saying and what we're recommending to patients? Because if you're going to recommend second-line treatments to patients as oral generics and not first-line oral generics, you're going to have to explain to the patients why you're making a recommendation. And so this can become a real problem. There are new International Headache Society practice recommendation guidelines. This is actually really a wonderful document. I highly recommend you all take a look at. And it has a more global perspective. In this document, the CGRP treatments are recommended as second line, but again, it's a global perspective. And for them, it has a lot to do with access and availability. And in the global world, anti-CGRP treatments aren't available in every country. So as a global perspective, they can't offer a treatment as first line if it's not available in some of the countries that they're discussing this to. The reason I think this recommendation guidelines is really important to read is it's laid out as a question-answer statement. So as a practicing clinician, this kind of statement is wonderful. You can go through the list and look at the question and then look at the answer. How do I treat a woman who's pregnant? This is one of the questions, and it gives you a whole set of guidelines. How do I treat an older individual with cardiac issues? You read the question and you can read the answers. I find it to be a really fantastic piece of literature and highly recommend. It's something that you kind of keep in your drawer when you have questions like, oh, what do I do for that patient who has heart disease and I'm not sure what the right preventive treatment might be for them. They have an acute guideline as well. Great document to go back to. Now, why do I think migraine-specific treatments might be something we think about first? Well, the data shows us that patients prefer this medicine. They stay on this medicine. Almost 60% of patients over the course of 6 months remain on anti-CGRP treatments, regardless of which one you look at, versus about 20% of patients when we're looking at treatments like topiramate, amitriptyline, valproic acid. And just so you know, topiramate, more patients stay on topiramate compared to amitriptyline. That's what our data shows us. And if you've ever tried the medications yourself or heard stories from your patients about side effects, that should be surprising to you. Because we all joke about topiramate. We all know what topiramate is called by all of our patients. And if topiramate is preferentially stayed on compared to the other treatments, that should tell you a lot about these adherence and persistence rates. And if I tell you that you only have one chance with that patient after that first visit, that you prescribe them a treatment and they're not going to stay on it, they're not going to come back and see you, and that's a missed opportunity to reduce the burden of disease for these patients. And so we always hear about economic costs. It's really expensive. Yes, these drugs are really expensive, as are all new treatment options out there. But guess what? If we start with this type of treatment first, and the patients do better, they don't come back to see us. They don't come back to the ER. They don't go to urgent care. And when you wrap the cost up, we're saving our patients about $100 to $1,200 per year. And that's also a cost savings that goes on to insurance companies. And I think that's really impactful. There's a drug cost, but so do the acute medications that cost money, and so do all the other healthcare utilization costs. So it's important we take a look at all of this together. All right, now I'm talking about preventive treatment. I just want to put it out there. I can't necessarily say the same thing about our acute treatments when it comes to anti-CGRP. At this time, still the triptans have strongest evidence. There is no head-to-head study with our current, ubrogepant, rimegepant, zavegepant does not have a head-to-head study with triptans, but all of the meta-analyses that have been done, including this one that was just published last December, consistently show that the triptans have better efficacy. If a patient really feels like tolerability is important to them, that is a separate conversation. But when we're looking at efficacy, triptans are still probably the one that has the most efficacy on there. All right, briefly, we can't talk about new things without talking about AI. There was a beautiful study that won our Wolf Award from American Headache Society that took a look at AI and predicting response to treatment. What I thought was really cool is we have actually lots of real-world evidence trying to predict response to CGRP therapy. And the AI studies had some agreement with the real-world response. What we found was that those that had a lower BMI had a better response to CGRP monoclonal antibodies, those that had fewer migraine days a month, those that had tried lower number of prior preventives and had lower number of prior triptan trials. So again, this is a story that really tells you the less disabled patient starting preventive early that is going to respond better to an anti-CGRP treatment. And the later we start it, the less likely they're going to respond. Another interesting thing is someone who has a higher BMI is more responsive to onabotulinum toxin A and topiramate. So again, really good clinical pearl. It can help you in practice when you're starting to make some decisions if you're seeing patients with different clinical characteristics. Information, right now we only have one type of botulinum toxin for chronic migraine, but there are ongoing studies looking at episodic migraine, and there are other botulinum toxins being studied. So something to be looking forward to in the future. We also have a new molecule that is being investigated called PACAP. Just briefly, it is a very complicated story. PACAP and VIP actually target multiple receptors, and it has been a very difficult journey to find the right target for PACAP. They first targeted one of the receptors, and the original trial was a failure. Again, another example of how drug development can be very complex. There is a trial that was positive that actually targeted the PACAP ligand, and basically is now in another phase 2 trial with the hope that it will be successful in the preventive treatment of migraine. So that's something to be looking forward to. I'm amazed. I have like so few slides and I'm still not going to finish them all. Okay. So one study I found really interesting this past year was a study looking at aura. Every time in a headache clinic, at least a few times a year, you're going to have a patient who has prolonged aura who ends up having an ischemic stroke. This study was amazing. It was small, but it really helps in clinical practice. Every once in a while, we doubt ourselves. Do I really need another MRI? Do I really need to order that MRI? This study shows us the signs that probably correlate with stroke, new focal neurological symptoms, changes of first symptoms, and an absence of headache. In the study, most of the time, the exam was normal. A third of patients with stroke had persistent symptoms. So yes, you really need that MRI. If the patient's having that prolonged aura, change in symptoms, get that MRI. And I think this really helps me every time I self-doubt and just order it, because again, like if 80% of the time the MRI is normal and 20% of the time you found something not good, you're still helping that patient. So migraine's more than a headache. We're really trying to move the field into treating past just the pain part itself. We have newer targeted treatments that are going to show great promise, but we definitely need more targets and studies that are starting to look at mixing treatments, like how does a patient do when we mix different options together. It's vital that we tailor the treatment to the patient. So I show you all this data to show you how to talk about this stuff to your patients in practice and how you might introduce different medications to the patients itself. These statements and these guidelines are there to help you in clinical practice if you're struggling getting the medication that works for your patient. Especially the AHS consensus statement was actually made to help clinicians fight to get the treatment for their patients. We're working on cognition for migraine and trying to get a better sense about it. And I just want to end, as Rashmi mentioned, about this idea with the new position statement from IHC, mentioning about the fact that we really need to raise our standards in migraine. Our patients are willing to accept quite a lot. They might not want to start prevention. They might not take acute treatment when they should. They might not even come in to see us. And when you ask them, why did it take you 20 years to talk to someone about this, you will always hear the same story. I mean, I guess it's really, I just thought it wasn't a big deal. Even though I lost my spouse, my kids don't want to talk to me. I haven't had a promotion. I throw up on the side of the road. I can't see when this happens. I'm in bed most of the time. I don't have any friends left. I am miserable. But really, was there something I could have done? Yes. Yes, we need to do more. And I'm not usually the person that says things like this, but we need to do more within research and within advocacy and within the clinical space. You can't push a patient to take treatment, but we can listen. And it really doesn't take long, I promise you. And just create a space for them to tell you their story and just to tell them, well, yeah, there is a possibility that you could do better. Are you interested in listening? And it's always amazing to me when they do and they tell me like how life-changing treatment has been for them. And we just need to set some better standards.